not very, very rewarding.
Okay, so any role of tetrathiomolybdate? This is a new drug which people are talking of in neurological Wilson's. Prem, do you have any experience with it?
Mike Shilsky is at Yale, and we've had some discussions about this. I think that there is increasing awareness about the potential role of this drug in treatment of Wilson's disease. What I actually like about TMB is that it can cross the blood-brain barrier. And in fact, if you have a patient who is neurologically incapacitated and you don't know whether, and they are decompensating and you need to consider liver transplant, this very difficult question about giving a healthy liver and patient remaining neurologically disabled, I think actually giving a trial of TMB and seeing if there is some neurologic recovery is in a sense a biomarker of how much parenchymal tissue is left.
So he may do better if he's transplanted.
Absolutely, it would be transplant first for me.
As a
but I think the other more prudent approach would be to treat him with TMB for a period of time, see if you get stabilization of neurologic disease. We're interested to know what Patrick and Ashish thinks. If there is stabilization and improvement, then he's a prime candidate for transplant, in my opinion.
So you have proved that, you have mentioned that you talked of Thomas Tazel presenting. So you are saying that the neurological symptoms have a good scope of improvement after liver transplant. And would you primarily transplant? The liver disease is not too bad. Would you primarily transplant for the neurological manifestations?
Well, I feel a bit insecure, flanked by these guys, but I will say so anyway. Now, if you do the MRI, there is no cavitation. If my neurologist tells me, yes, there are changes, but it doesn't look severe, there doesn't seem to be a lot of cellular loss, and I've run out of therapeutic options, then I think it's a reasonable undertaking. But again, I think that really a prudent approach would be to try TMB for a period of time, and I would not set very stringent therapeutic goals. I would want stabilization of neurologic disease, maybe some objective signs of improvement. It tells me there is enough parenchyma to recover there, and transplant is the best, most effective decoppering procedure in a sense.
Okay, so that's very helpful, and I think we'd like to end our case discussion. Thanks to all the panelists. And before you go away, are there any questions? Sorry, are there any questions from the audience? Yeah. Get the mic working.
Therapy.
Mic working.
With penicillamine and zinc, how will you monitor?
When you are on combined therapy, you monitor it as though you are only on the chelator. You forget the zinc part of it for monitoring. Follow the principles for monitoring for only if the child is on penicillamine. Even if you are giving both.
Yeah, sir. If both are giving, zinc is supposed to decrease the urine copper. When you on zinc, the ideal urine copper should be less than 75.
Right.
And when you monitor with penicillamine, the urine copper will be 250.
Correct.
So how you monitor with combined therapy?
So that's why when you're giving both of them together, you forget that you're giving zinc and monitor it like how you would monitor it for the chelator itself. Those are the regulars. So you'll keep it between 250 to 500. You'll make sure your serum free copper is between 5 to 15. Everything else, not like how you monitor for zinc. It goes out of the window then. If you're only giving zinc, then you want to have a low urinary copper of 75, etc., etc.
After achieving normal
please stay back. I just want to make a few announcements, so just please stay back. Yeah, somebody was.
After achieving normal transaminases, after how many years of such normal enzymes can we switch over from D-penicillamine to zinc as maintenance?
As soon as it reaches normal, most people would even do it at 6 months. There are some institutes who do it at 6 months, some do it earlier. I keep them till they maintain normal, and within a year or two, I put them on zinc. Initially, I used to make it 2 or 3 years because I was a little concerned with the zinc preparations that were available in India, and I would, as far as possible, not put them on zinc unless I had to. But now with zinc being available for diarrhea, we're getting very good zinc preparations. So generally within a year or two, I put them on zinc. But I don't think there is any specific marker to say, okay, now I have got this. Of course, they need to have the urinary copper between 250 to 500, so they should have reached a negative copper balance. LFT should be normal, complaint should be stable, everything should be fine. But I would try to put them so usually it's on an average it's 1 to 2 years for me.
What do you prefer, zinc or deep pen as a maintenance therapy, sir? Bavdekar, sir. Yes.
Nowadays, zinc.
Do you think it really works, zinc, as compared to a lower dose of deep pen for maintenance?
Well, unlike adults where you have a maintenance therapy of deep pen which is lower, children there is no maintenance therapy. Children, the therapy, initial therapy and maintenance therapy of deep pen is supposed to be the same.
Supposing you've gone up to 20 mg per kg during the acute phase, and then within, let's say, 5 years of time, you feel this is satisfactory. Would you come down to 10 mg per kg?
No, I don't.
Or would you go to zinc?
That's what I'm saying. There is no maintenance lowering of dose of penicillamine for how you do for an adult. You start at 1500 and come down to 750. For children, there is no lowering of the dose for maintenance. So either you have to continue the same for maintenance. I don't do that. I mean, I would either do that or I would give zinc, but I would not lower the dose of penicillin.
And in your experience, do you feel the combination works better than deep pen alone? Because there are conflicting reports from the West saying combination therapy does not work.
Okay, I don't know. I have not really studied it from that point of view because everyone I put on for the last 3 or 4 years goes on zinc and penicillamine. So I've not done a study, and I don't have people who are only on penicillamine as to compare it with.
Thank you.
Yeah, Akash.
Of the zinc salts available, is zinc acetate superior to zinc carbonate and zinc sulfate, or all three are similar as far as therapeutic efficacy for Wilson is concerned?
All zinc are fine, whether it's gluconate, sulfate or acetate as compared to its efficacy. It is just sometimes the tolerability. Initially it was thought that zinc acetate is far more tolerable than the sulfate because sulfate is supposed to cause more acidity. There is some people now feel that gluconate in fact is slightly better tolerated, but in terms of its efficacy, as long as it contains the elemental and zinc of the same, it doesn't matter. But it has to be given on an empty stomach for it to have an efficacy.